Good morning, everybody. I would like to thank Norberto and the organizing committee for the invitation. And so it's showing up. So what I wanted to talk this morning is some neuropathological findings that we have been studying on patients with temporal lobe epilepsy. And we have a chance to have a surgery epilepsy center which performs surgery for intractable patients. Let me see. Okay. So let me see if it works. So what I'm going to talk is some background information regarding the semiology of the psychiatric manifestations of these patients, and regarding the history, natural history of temporal lobe epilepsy, and some of the neuropathology findings that we have been doing with these patients. And also highlight some of the limitations of the human neuropathology studies. So, as you know, temporal lobe epilepsy is particularly associated with schizophrenia-like psychosis. And this has been shown since the, actually much earlier, but since the 60s. And we know that temporal lobe epileptic patients also have higher rates of psychosis than the general population. And although when our friends from the psychiatry, they say that it's not possible in an individual basis to clinically separate them, as a whole, the syndrome was considered like differed a little from the true schizophrenia in some ways that I'll comment later. We know also that there is a negative correlation between, actually this studies from the 70s that pointed out that usually patients with the schizophrenia-like psychosis usually have neocortical lesions such as small tumors, hamartomas, and focal dysplasias. And usually there was in these early findings that the medial temporal sclerosis would be actually a protective. But as you know, you see, and it is not quite true. And also with, we heard from the lectures of Dr. Kenner that not only the temporal lobe, but also the frontal lobes are related to these symptoms. And I want to highlight that only a limited number of studies actually try to correlate these symptoms, the psychotic symptoms in TLE patients, with some structural changes in the epileptic tissue. So, as I said, schizophrenia-like psychosis there are some little differences from classic schizophrenia. Usually they lack of some schizoid primordial personality. Usually they have a warm affect. The preservation of affect is also something that is usually found in those patients. This is more like a traditional thinking, but some patients could have common religious coloring and of the ideas, the paranoid ideas. And one also, the big difference is that the deterioration for severe hebephrenic states is not found in these patients. And also there is little evidence of a genetic predisposition to psychiatric illness in relatives. For also mood disorders, the association between epilepsy and depression has been actually referred for a long time. This is the very old statement from Hippocrates that trying to correlate the common pathway from that would in epileptics would determine if the melancholics goes to the body, they would have seizures, and if there is go intelligence, they become melancholic. This is something that was related, but actually in the late 19th century, there was some reports that also acknowledging that patients with epilepsy also present with depressed mood, some misanthropy, and a tendency for suicidal ideas, or even suicide, true suicide. And the prevalence of the depression in patients with recurrent temporal lobe seizures, they range from quite a lot, but usually 2 to 3 times than the general population. So, and there was also some subtle difference in terms of phenomenology of the depressive in TLE patients. And the most frequent symptoms include feelings of anhedonia, guilt, and some suicidal ideation. And also some reports that other authors reports that are associated with that, anxiety, some feelings of depersonalization, and more, less frequently, some manic, depressive, psychotic manifestations. Usually, our colleagues from the psychiatric division show, and when they evaluate our patients, they said that usually the symptoms are milder than true major depression, but usually there is a huge impact on their daily activities of these patients, some problems with social interactions, and the quality of life is really poor, as was shown in the previous lectures from Dr. Shatter and Dr. Kenner. And quite often and quite frequently they need some antidepressants. According to the relationship with seizures, usually the depressive symptoms may be periictal or ictal and interictal ones. The periictal and ictal ones, usually they have a very good prognosis after a surgery, because when you decrease seizure frequency, they usually disappear. But interictal mood depression usually is really hard to treat, and sometimes this is one of the impediments for the indication surgery if the patient is not in a good control of their depression. I took this allegory from Asla in the talk that highlighted, and I like this idea that it's really, really difficult to study any kind of comorbidity in such a huge context of when we consider all types of epileptic syndromes. So this is what also was mentioned yesterday, that if you took as an average and to want to eat this elephant, this would be a big problem. The way that we can try to solve this, and Asla suggested, was to actually separate them into specific endophenotypes. And in the condition of the pharmacoresistant temporal lobe epilepsy, we have actually a more homogeneous phenotype, not completely homogeneous, but we have a typical situation that patients have the more severe spectrum of seizure intractability, and usually they share some neuroimaging and some other parameters like biochemical, neuroanatomical, and cognitive impairments that maybe we can, as a more homogeneous group, study that. So, and what is the natural history of mesiotemporal lobe epilepsy? Usually, there is a history of an initial precipitating injury that usually occurs by the early first years of life, right? And more frequently, in the series, this may vary from 30 to 70% of the cases, and usually febrile convulsions are more frequent. But we also have some other types of injury that, as a common denominator, they call some, they lead to some damage in the brain. So after that, the patient or the children may recover and never have a seizure again. This happens with the febrile seizure, is a short duration, and there is no seizure recurrence. But we can have, after a couple of years, a situation that the patients start to having complex partial seizures. And then the seizures can be controlled with drugs, but also could lead to a pharmacoresistance, and probably a resectomy is one of the best therapy. So then we have the tissue that we can also do histological and also molecular studies on this. And what are the histopathological changes that have been demonstrated in either human tissue and also in experimental models? So it's a huge number of changes that probably most of them are due to plastic changes induced by injury. And so we have selective neuron loss, dendritic hybridization, axonal sprouting, and changes in receptors and transporters, and also in astrocyte proliferation. And also we saw that in the previous lecture of Lydia that also has changes in angiogenesis, extracellular matrix proteins, and also some neurotransmitter systems that also can be changed. But I'll be restricted to some changes that are related to severe neuron loss and axon sprouting. As you know, this is the mossy fiber sprouting is one of the hallmarks of the TLE, and we can see here this reorganization of the fascia dentata molecular layer as compared to a control situation. And we know from experimental studies and also clinical ones that this is related to hyperexcitability, and there is a huge debate and with different theories regarding if this one of the substrate of hyperexcitability. And we also know that the neurotrophins are essential for to promote this sprouting in both experimental models in vivo and in vitro. So what are the questions that I wanted to address? Is it possible to distinguish structural and molecular changes in the hippocampus of these patients which present or not psychiatric comorbidities? And are these changes associated with specific conditions or behavioral states? So what I'm going to present, most of the studies were performed by Ludmila, who is in the audience, and she has been working with us as either when she was a graduate student and now as a postdoc. So in this first study, we actually is a first series of these patients, and they were evaluated by our psychiatrists, and we had a group of patients with either interictal psychosis, major depression, and without a history of psychiatric disorder, and were compared with non-autopsy non-epileptic controls. And as you see with demographic data from of this series, that there was several clinical and demographic data that there was no difference. But we see here that patients with psychosis-associated epilepsy have a mean age when seizures became chronic, when they start having complex partial seizures, started later on. And also that the secondary generalized seizures are more frequent in the patients with psychiatric comorbidities. And also when we look at the memory verbal tasks, patients with psychosis have a poorer performance than the other groups. So patients with psychosis develop recurrent seizures at later ages than the other groups. As you see, the generalized seizures were more frequent in patients with psychiatric comorbidities. And also for the memory performance test, patients with psychosis had the poorest performance. And when we look at the neuron density, this pattern for neuropathologists is quite classical when you see the profile of severe cell loss in some subfields. And as you see, most of the patients have the groups have a similar profile, but the depression group had a little, in the CA4, a little more spared, and it had achieved a statistical significance, and also in the entorhinal cortex, patients with psychosis had a lower density than the controls. But the pattern is very similar to the other TLE groups, and the subfield CA4 is more preserved in the depressive group. And when we look at the sprouting of the mossy fibers, we see that there are differences in the intensity of TIM staining, but also, let me see. But also when we see the length or the thickness of the sprouting, we see that the depression group has a thicker visible sprouting. So psychotic patients presented a lower mossy fiber sprouting than the TLE with depression and TLE without comorbidity. And this increased sprouting, the thickness is different from both the psychotic and TLE without a comorbidity. So, and when you see the correlation of clinical variables, we see that a higher proportion of patients with depression and with psychosis presented the secondary generalized seizures. And patients with psychosis presented poorer performance than other groups in the memory tests, and which is in accordance with other studies that show that schizophrenia patients have usually very poor performance on memory tests. And depression patients had a similar performance in memory tests when compared to patients without psychiatric comorbidities. And then this second study, actually, we just received the proofs the last week, and actually Ludi used a different series, and besides doing cell density studies and TIM staining, she also looked for the neurotrophic factors, neurotrophins, NGF, BDNF, and NT3, and with a more or less similar series with approximately the same number of patients. We also found very similar findings that we found in the previous study. But most of the clinical variables, like the presence of an IPI, age of the first seizure, seizure frequency, epilepsy duration, the size of hippocampal sclerosis, the dominance of handedness, and all were not different from among epileptic groups. Also with the density, neuron densities, we see that the pattern also it's the same and very similar to what we see in other neuropathological studies. And also we saw the same finding of in depressive patients with a thicker visible sprouting in the inner molecular layer, actually reaching also the outer molecular layer, and also some changes in the gray value or intensity of this staining. The same results of the previous studies. And when we correlate with clinical variables, we found that this neuron density were correlated with seizure frequency in several hippocampal subfields that present severe damage. These molecular scores also correlated with mossy fibrous problem with clinical seizure frequency. And the dispersion of granular cell in the superior blade correlated inversely with CA4 density, suggesting that the dispersion could be related to loss of granular cell original targets. So these findings actually are commonly observed in experimental models of epilepsy and also some studies in humans, and is associated with both brain damage-induced plasticity. When you look at the NGF immunoreactivity, we see that some labeling depends on actually in the cell loss that we see. But especially in the granular cell layer, we see there is a strong labeling in the granular cell layer. Here we see the dispersed granular cells. And we also see some labeling in non-neuronal cells like astrocytes, and especially in the subfields that we have a huge cell death, and astrogliosis is very prominent. So when we look at close to the fascia dentata, we see that the depressive group have a higher expression of NGF in comparison to controls and also with the psychotic ones. This was a correlation with the mossy fiber sprouting and the length of the mossy fiber sprout and seizure frequency. No difference in immunoreactivity was seen when patients were taking or not taking the fluoxetine, and patients with the psychotic group which were taking haloperidol show less NGF immunoreactivity in one of the subfields. And considering seizure types, patients with secondary generalized seizure exhibit decreased values of immunoreactivity than those with presenting only complex partial seizures in the hilar region. So for BDNF, we have a very similar pattern in the aphasia dentata, and we see also the dispersion and increased labeling here in comparison to the control. And also, in some fields, we see that the control group has a increased staining, showing that probably there is no problem. The postmortem delay is not a variable that could decrease the epitope or antigenicity of the antibody. And when we look at the density of the granular cell layer, we also see that there is an increase in labeling in both TLE and depressed patients, and it correlated positively with the density of epileptic density of cellular in the epileptic patients in the hilar CA4 subiculum, but not with mossy fiber sprouting or dispersion of the granular layer. Regarding the patients with depression, there was greater immunoreactivity in CA1. It was the only finding that we see with the patients taking fluoxetine. And also, this was almost a general trend. Patients with psychotic, which were taking haloperidol, show decreased expression of BDNF in the hilars and versus the ones that were not taking it. And for the NT3, we actually was quite disappointed because we only found a moderate NT3 expression in neuronal and glial cells. And for blood vessels, as you can see here, there was a faint to strong in some cases. And in fact, after Lydia's lecture, I was looking at my slides, and I kind of found that probably the epileptics has a little greater vessel density than the control ones. But when we do the quantitative studies, we didn't find any different among groups. One thing that we have to acknowledge, there are quite great some limitations of studies with humans. And one of them, the first of them, is that when we are looking at the tissue, we are actually seeing a late picture of a long history. And I was, as an analogy, would bring probably the old guys from the audience would remember this movie, but probably the young ones, I don't know if you were familiar with that, but it was a film in the 70s that there was a fiction movie that the astronauts go to a planet that was dominated by apes. And at the end of the movie, we realized that there was not an alien planet, but it was an Earth, and it happens because they went to future, and they actually were seeing or facing a planet that was kind of destroyed by the atomic or nuclear war. But as an analogy, patients which were studying had a history of precipitating injury in the first years of life. Then they start having seizures, and by the end of the first decade, they start to have the complex partial seizures. And then they were treated with anti-epileptic drugs. There are different drugs, and when they reach pharmacoresistance, was a couple of years further on. And at the end, a temporal lobectomy is performed several years after the beginning of treatment. So we have to face with some, that probably there are many pathological changes that we find, but which are the causal ones and which are the ones that are just a consequence or even a phenomena or compensatory, we don't know. And also, as acknowledged by Dr. Kenner, when we are doing neuropathology studies, we are looking at the structure that we are available for, to study or to address with histology. But we know that there are several other interconnected areas, and there are a prolific number of imaging studies that show that even in the contralateral areas we have extra temporal damage, and especially related to frontal areas. So this actually should be addressed by prospective neuroimaging studies with markers that would be somewhat correlated with histopathological substrates. So that's these studies are necessary to establish the causal relationship between the structural changes and the behavioral dysfunction. So in conclusion, we believe that we provide a demonstration of a differential neurotrophin expression in human temporal lobe epilepsy patients with and without psychiatric comorbidities, supporting an association between mossy fiber sprouting and expression of some of the neurotrophin, especially NGF and BDNF. There was an association with the use of haloperidol and the increase of neuron loss and decrease of neurotrophin expression, and the relatively high prevalence of psychiatric symptoms in MTLE patients suggests probably that the mechanisms and there are shared mechanisms in both conditions. And as I said, with one of the limitations of the study is due to the characteristics of the study, it was not possible to define which exact variable might contribute to the genesis or to the maintenance of the symptoms of psychiatric comorbidity. And finally, the study probably will not lead to a complete understanding of the epilepsy or epilepsy-related psychiatric disorders in MTLE, but we believe that such studies or such tissue from patients with epilepsy surgery constitute a unique opportunity to concurrently examine the changes, structural changes, biochemical markers, and relate to comorbid psychiatric symptoms in patients with a chronic epilepsy. I would like to thank you and acknowledge all the students, and also Norberto, Rodrigo, who has been with us for quite a time, and then how now he's in Natal, and also our financial support agencies. Thank you very much.